Today, the head as distinct from the neck. I did this last year. I don't imagine that there's any particular reason for the numbers to change greatly this year. The point of this slide is to let you know that plain films of the head almost not done anymore. And when I was growing up, that's the only thing you could do, was a plain film of the head. If you want, now this is unbelievable. They're just rare. Everything is done with CTs and MRIs, and clearly that's what I'll spend most of the time on. I mean, I would feel terrible if you couldn't tell anything in a plain film of the skull. And so I've just shown you an AP and a lateral later. I remind you that where you have radiolucencies, you have air. And therefore, this radiolucency here is the frontal air sinus. Even though there's bone in front of it and bone behind it, it is still more radiolucent than the rest of the skull where there is no air. You can actually see, and this is not air though, it must be due to fat probably, or at least no bone, just soft tissue within the superiorbital fissure. So the superiorbital fissure, being soft tissue, does not appear as radiodense as bone does. And none of these other things do I have to spend any time on other than to say that it looks to me like that third molar is probably still unerupted. It's probably still in the mandible. Of this lateral view of the skull, by far the most important thing is this pituitary fossa, the bone surrounding it. It's called the sulla turcica. Sometimes clinicians just refer to the fossa as the sulla turcica. And again, nothing particularly interesting that you can't figure out on your own. This I don't think you could figure out on your own. So I'll ask someone what they think it is. I will point out here, remember on this one, this is the hard palate seen in sagittal section. Here is the hard palate in this person seen in sagittal section. So this is not part of the hard palate. It's bone with radiolucency, a big radiolucency, superior to it.
Maxillary sinus?
Yes, very good. That is the floor of the maxillary sinus. Maxillary sinuses can be quite big. Not that you would ever look at these things in plain film anymore. Never done. So we'll jump right immediately into CT, which is where most of the studies reside. This is one through the mouth. So this is C2, C3. And some things we know about from the neck. This person's had contrast, so this is contrast being drained by the internal jugular vein on the right side. Here it is on the left side. I've not labeled it. I've labeled the left internal carotid artery, which at this level is slightly anterolateral to the internal jugular vein. And here I did not label the right internal carotid artery. How do I know that's the external carotid? I have to tell you, the only way I know that's the external carotid is I've looked at these and could trace it. And if you follow this little dot, right now, I'm just going to go quickly. You can see it runs over to position behind the mandible. And we know that's what the external carotid does. It shoots laterally, takes up a position behind the ramus and the mandible, and then turns up. So that's the only way I knew that was the external carotid. I would expect to see an external carotid here at C2, C3, because the bifurcation is generally around C3, C4. So I expect it to be there, but I've got other little things here which are probably branches of it, and it's not exactly clear to me which would be it and which would be branches. Vertebral artery coming up through the transverse foramina of the vertebrae. Now, here is a grayish thing on the outer surface of the ramus and the mandible. And in fact, we're right down near the angle of the mandible here. So the only thing that's on the outer surface of the ramus of the mandible, near its angle, that extends all the way, the entire depth of the ramus, is the masseter. And down near the angle, the only thing that's on the inner surface is the medial pterygoid. So we will see these continuing as we go up the section, but these are the first of the masticatory muscles we can see because they attach down at the angle. Medial pterygoid, medially, masseter, laterally. So we're just coming up now the section, up. You're seeing more of them. Nothing very exciting going on. We now, at this point, are catching the medial pterygoid as it's coming down to its insertion, so it's not attaching to the mandible at this point. We're approaching its origin. And we're starting to see another little muscle crop up here right along the anterior edge of the mandible. And I know that the muscle that inserts into the coronoid process, which is on the anterior edge of the ramus, and actually has a tendon and a little bit of muscle fiber which runs down the anterior edge of the ramus, is the temporalis muscle. So that's what we first see now. And we continue up. Styloid process is just there for reference sake, or just to let you know you can see it. And now we have a different muscle right there, which I've given a different name to. And why do I call that the lateral pterygoid? I can't see anything hardly about it. But why am I so certain it's the lateral pterygoid?
It's lateral to the pterygoid process.
It's on the lateral surface of the lateral pterygoid plate, 100% correct. Here's the medial pterygoid plate right there. Here is the lateral pterygoid plate. Here's the medial pterygoid plate. You see that the muscle which arises on the lateral surface of the lateral pterygoid plate must be lateral pterygoid. And of course, we know that the medial pterygoid rises from the medial surface of the lateral pterygoid plate and also from the floor of the pterygoid fossa. Temporalis is getting a bit bigger as we come up. I'm going up this section now. We see a beautiful maxillary air sinus. Obviously, this is nasopharynx back here, and this is the nasal septum in the middle and the nasal cavity between are the black things, the radiolucent things. Point out the dens, which we learned about last time. There's the anterior arch of the atlas and the superior articular, or at least the lateral masses of the atlas. The vertebral artery coming up through the right transverse foramen of the atlas. Here's the vertebral artery on the left side, so it tells you that these are not exactly transverse. Very hard to get a perfect transverse section. People, when they lie on these machines, sometimes they tilt their head a little bit to the right, a little bit to the left, and you're going to see things on one side before you see them in the other. If we go down the section again, here's the left vertebral artery right there, coming up through the transverse foramen of the atlas on the left side. Here's the right vertebral artery. But we see the left start, and we see quite a bit of it curl around the posterior surface of the superior articular process as it's going to work its way towards the foramen magnum. We'll see the right one do that on the next section up. Here's the right one coming around. We still continue to see the left. Again, here is our internal jugular vein. Here's the internal jugular vein. On the left side, very different sizes. This is quite typical. Very different sizes. This is a question whether anybody read clinical sidelights. What would be the size of this internal jugular vein if the person was sitting or standing? The same?
It'd be almost empty.
It'd be almost empty. Someone has read clinical sidelights. I didn't know this, and I've been teaching anatomy for, 50, 60 years? I can't remember. I did not know until this summer that when you are in the erect position, your internal jugular veins are essentially collapsed. And the blood flow from your head is coming through the vertebral venous plexus primarily. Only when you are lying down, as happens with all people who have CTs and MRIs nowadays anyway, maybe in the future that will change, do these internal jugular veins fill up with blood. So they look this way because this person's lying down. And I just labeled them, so we'll follow them as we go up the section to see where they go, but we know where they go. So there are different sizes. That's in real life. This person has different size internal jugular veins. The muscles are not going to do anything, terribly interesting. Temporalis is getting bigger, the masseter is getting smaller, and we see the lateral pterygoid finally going to its insertion in the mandibular condyle. We see the left internal carotid artery entering the carotid foramen of the skull. If I go down a level, we see the internal jugular vein exiting from the jugular foramen of the skull. Again, we're seeing things happening on the left side of this person that are differently than on the right because these are oblique sections. I put little stars here. I'm going to go all the way back down again because I forgot I did this. Here's the vertebral artery on one side, the vertebral on the other side. I put little asterisks by them so we can follow them up as we're going up. So that's those asterisks referred to. Again, we're at the point where the internal carotid artery on the left is entering the carotid foramen, and the internal jugular vein on the left is coming out of the jugular foramen. Haven't reached those levels on the right yet. Still haven't reached those levels on the right yet. Still, we're getting very close to the jugular foramen on the right. Now we see the right internal carotid entering the carotid foramen, which is in the petrous temporal. And at this point, on the left, we actually are high enough that we can see the carotid artery, having previously entered the internal carotid foramen, shooting forward in the carotid canal of the petrous temporal on the left side. We'll see this on the right in a section that's a little higher. And now we see the internal jugular vein on the right side coming out of its jugular foramen. And we continue to go up. Our vertebrals are getting very close together. Here's the carotid on the right side, passing through the carotid canal in the petrous temporal. Did I miss the sigmoid sinus? Here it is. I forgot to mention it. Here's the sigmoid sinus, which will connect up to the internal jugular vein. That'll be true on both the right and left sides. And then this. What is that? The basilar artery. Everybody knows that. Excellent. And we're now, we've lost the masseter, we've lost the medial pterygoid, we've lost the lateral pterygoid. The only masticatory muscle which extends superior to the zygomatic arch is the temporalis. I just been labeling it, but I haven't been talking about it as we've come up. Now we're getting here to the orbit, or we're at the orbit. You can see here that this little radio-dense thing is the lens. The lens is more radio-dense than is the vitreous, which fills up all the portion of the eye posterior to it. Now we're starting to see two muscles. I haven't bothered to label them, but it's pretty obvious what they are. Lateral rectus and medial rectus on both sides. Keep on coming up the section. I did label them, remember. This is the trick here. I'm going to go back down to the bottom of the orbit. We're at the bottom of the orbit. I'm going to come up. I don't see the optic nerve. I haven't reached the optic nerve yet. I see these things, next section, the optic nerve. So this is something passing from lateral to medial, inferior to the optic nerve, not far from the optic foramen.
Ophthalmic artery?
Yeah. What's your reason for saying that, other than maybe, you may know why it's there, but what's the reason for saying it? Where does the ophthalmic artery generally run?
Superior. Superior to the optic nerve?
Superior to the optic nerve. So why this runs inferior to it? So why do you think it's the ophthalmic artery?
It's a variation.
That's right. Good. Very good. In about 25% of people, the ophthalmic artery crosses inferior to the optic nerve. It is always the thing which is running from lateral to medial in a fairly sharp course from lateral to medial. And that's true whether it's inferior or near the optic nerve, whether it's inferior or superior to the optic nerve. Very good answer. Here's the optic nerve. We come superiorly. These must be, I don't think these are labeled, that must be the lacrimal gland on this side and the lacrimal gland on that side, which sit right very far forward in the orbit, superolaterally. Here is something which is definitely superior to the optic nerve. Now, it crosses the optic nerve, but it doesn't zip across. I mean, that's not the anatomic term. But the ophthalmic artery makes a very short, quick crossing of the optic nerve. This is making a leisurely crossing of the optic nerve. In fact, this is something that's running mainly anteroposteriorly, not so much mediolaterally. It's crossing the optic nerve because the optic nerve is obliquely positioned. So this is essentially an anteroposterior structure which causes the optic nerve because the optic nerve is oblique. And if we can, and this is definitely superior to the optic nerve. And if I go up one section higher, here's the superior rectus. So this is the structure which lies immediately inferior to the superior rectus muscle.
Ophthalmic vein.
Yes, all of you who said that said it correctly. That's the superior ophthalmic vein. Superior ophthalmic veins, they never look like anything in the section. They look like a piece of stuff. It's a real thing that you can pick up in your forceps that runs front to back inferior to the superior rectus. I don't care what it looks like. That's what the superior ophthalmic vein is in dissection. And now we're just getting to nothing very interesting, brain, and things like that, which don't do much for me. So here's the internal occipital protuberance. I haven't been following this, but we must know what that is. I won't even ask you. That's superior sagittal sinus. This is either inferior sagittal or more likely the beginning of the straight sinus. These two things should connect with one another at some point. Maybe they did they did down here, all right? Lower in the section. So this was here's junction of straight and superior sagittal, and then as we get higher and higher, it'll turn into inferior sagittal, this one, and the great cerebral vein of Galen. All right, now going back to one of our previous sections, I'm going to make a big deal of this. And this is one of the sections we looked at. So, but here's the internal jugular vein on this side. Here's the internal carotid artery on this side. Here's the internal jugular vein on the left, internal carotid artery on the left. Here's our medial pterygoid, our lateral pterygoid, our temporalis, our masseter. Mastoid air cell on this side. It's higher on this side, so we don't see it yet on the right side. This bump that one sees projecting into the nasopharynx from posterolaterally is the torus tubarius. That's the end of the cartilaginous end of the eustachian tube, or the end of the cartilaginous portion of the eustachian tube. The cartilaginous part of the eustachian tube forms its medial wall. So that means that the actual eustachian tube would be lateral to this torus tubarius. It would be here somewhere. Of course, it's collapsed. So the eustachian tube is collapsed, and so you don't see it in this particular person. If the person had air pumped through into their middle ear, you might see it. So I'm looking at something which is not lateral to the torus tubarius. I'm looking at something which is medial to the torus tubarius. This is called, in your books, pharyngeal recess. But every radiologist in the world calls it the fossa of Rosenmuller. And they make a big deal in every CT scan of reporting on the fossa of Rosenmuller. And the reason they make a big deal of it is because pharyngeal cancers tend to start here. So they always say, normal fossa of Rosenmuller, or horrible thing. I couldn't find a CT of a pharyngeal cancer. I did find, here's an MR, here's our torus tubarius in the MR. The fossa of Rosenmuller is medial to the torus. This person had a lipoma, which is a benign tumor in their fossa of Rosenmuller, so I just thought I would show you that. I couldn't find a real cancerous condition. Now, when you look at CTs, you know this from when we look at the heart and the lungs and things like that. You can have windows which show you bones very well and vessels very well, or you can have windows which are sort of softer. It can show you the lung and things which are less radiodense. So this is maybe a standard CT that we looked at of the skull. This is one which is emphasizing bone and making all soft tissue structures very, very dark. Why might you want to do it if you were interested in actually seeing that the bone of the skull is in fact bilaminar with an inner table and an outer table and a diploe in between those two? You can't really see it on this one, which shows too much soft tissue, but if you change your settings, you can actually see the two different layers of the skull bone and the diploe in between them. Again, this is showing mainly bone. This is showing soft tissue and bone. And I show you this only because you can see so well in the one which shows mainly bone, the structure here, which is the foramen ovale. And that little radiolucency posterolateral to it, and that is, right, very good, foramen spinosum. All right. So if you're really interested in bone, you will change your settings so that all the soft tissue stuff doesn't obscure the things you're looking for. And now we can go into, this is going to be a nice short lecture, I think. MRIs. This tells us a T2 weighted MRI. We know in T2 weighted the big difference between 2 and T1 is standing fluid, right? Standing fluid appears very bright in a T2 and not in a T1. Fat appears bright in both of them. Bone appears black in both of them. And here's the standing fluid that is our cerebrospinal fluid around our spinal cord. This thing, for years I didn't know what to say that was, and then one of the students in the class who had been a radiologic technician said, that's what happens in an MR if a person has a filling in their tooth. It makes this big ugly thing that looks like a tumor. So it is an artifact of a filling in the tooth. We're going to see exactly the same things that we saw in CT, so I don't really have to spend a lot of time. We're going to see some things much better. First, I want to point out to you this black stripe right here, and here on the here's one there with some white in between. That's our mandible. Again, bones don't appear white in MR. They appear black. The whiteness we see here is, in fact, the fat in the fatty marrow of the mandible. The actual bone of the mandible is this black thing here and this black thing there. And on the right side, it's this and that. So we're looking at a muscle on the outside of the ramus of the mandible and a muscle on the inside of the ramus of the mandible near and attaching to them, and that's what these clearly are. One thing, and I'm going to go because I didn't think to mention, I'm going back very quickly if I can, to the ones we looked at before. Here's the masseter. Here's the medial pterygoid. I'll go back to here. I know this is not masseter. But I can't tell from looking at this that I know what it really is. And in fact, this is really probably this thing here, sort of goes behind and then overlaps the masseter. You can see a little indication right there. That's the parotid gland. We know the parotid gland sits behind the ramus of the mandible and overlaps the back part of the masseter. You cannot distinguish it in a CT because the radio densities of the two things are identical. If you really want to see, I never know which way I'm going on these things. If you really want to see a parotid gland, you do an MR. Because now it doesn't even resemble muscle. It's this beautiful, white, floccular sort of thing. Here's the parotid gland on the left side. Here's the parotid gland, big one too, on this person's right side. Maybe I can see, a retromandibular vein or external carotid artery, but I can't really identify them. I can't, anyway. But parotid glands look very different than muscles on MRI. Continue up this section. Medial pterygoid masseter, mandible, and ramus of mandible in between them. What is it? I'm trying to figure out what we got here. I mean, I know what this is, but I'm trying to figure out how to tell you to figure out what it is. The real question is, you have to pretty much know what this is, in my opinion. Anybody have any idea what that is? If I go down again, I see this. This is a big clue. That's the dens. All right. That's the dens. Here's the vertebral arteries, left and right, black in an MR, unless there's been a magnetic resonance angiogram. So this is the dens. So this is part of the atlas, and this is part of the atlas. If I come up a section, boy, I can barely see what's going on. Dens, part of atlas, part of atlas. The question is, what's this? Why am I sitting here trying to figure out what the hell this is? Because you have these two neck muscles, longus capitis and longus coli. The longus coli ends on the anterior tubercle of the arch of the atlas. So if it extends beyond that anterior tubercle, it's longus capitis. This is not ending there. This is going to continue superiorly to it, so therefore must be longus capitis, because longus coli ends at the anterior tubercle of the arch of the atlas. Continuing up, yes, you can barely see here a little black stripe right there which is the lateral pterygoid plate. Here is the remnant or the origin of the medial pterygoid muscle from the medial surface of the lateral pterygoid plate. Here's the lateral pterygoid arising from the lateral surface of the lateral pterygoid plate. And the lateral pterygoid is heading over towards the neck of the condyle of the mandible. Masseter and temporalis look like they did in CTs. How about this thing? A big longitudinal structure. Yeah, the inferior conch. Right, very good. Here's the nasal septum. Here's the nasopharynx. A little hard to see the torus tubarius at this section. Maybe it's not so bulgy yet. But these are the inferior nasal conchae on either side. There's one. Coming up again, nice inferior nasal conchae. Now we see the torus tubarius on this side right there, and we see the torus tubarius on that side right there. So here's the fossa of Rosenmuller there, fossa of Rosenmuller there. Here's the, I have a question. Well, when you see something like this running at 45-degree angle, right through the middle of the skull, and is magnetically loosened, what do you figure it is? Yeah, that's the internal carotid ring right through the carotid canal of Petrus temporal. Coming up because our nice basilar artery. This is all cerebrospinal fluid on the ventral side of the brain. Coming up again. Coming up. Up. Ah, look at that. Look at that right there and that right there. Boy, that's a tough one. I can only guess what it is. Anyone else have a guess? Oh, good guess. Nasolacrimal duct. I think that's the nasolacrimal duct. Clearly has a little standing fluid in it on one side. Coming up again. And now we can tell, again, that we have T2 because the vitreous is bright white in a T2. We'll see a T1 later. The vitreous will be gray or black. Superior sagittal sinus, flowing blood is dark in both of them unless you do a magnetic resonance angiogram. I'm guessing since we're coming up, let me go back down again. No, coming up, section thickness is greater in MR, at least in the MRs done currently. They may eventually improve it, but section thickness is greater, so you move in bigger chunks at a time. This looks to me like it's probably inferior rectus on this side. Here, more obviously, is lateral rectus and medial rectus. On the left eye, medial rectus, lateral rectus. A thing which is zipping right across from lateral to medial. I don't have to ask you what it is because now you know the thing which zips right across from lateral to medial, whether it's crossing the optic nerve on its superior surface or crossing the optic nerve on its inferior surface, is the ophthalmic artery. So that's what the question mark thing is. Here are some nice ethmoid air cells in the lateral wall of the nasal cavity. Continuing up, what about this thing? Going mainly anteroposterior, and in fact, if I go down a level, here was our optic nerve. In fact, if I go down another level, you can almost start to see the optic nerve here. So in this particular case, coming up one level, this artery is crossing superior to the optic nerve. Coming up one more level, here's something runs front to back, crossing superior to the optic nerve. Yeah, superior ophthalmic vein. And the next thing we should see here is what?
Superior rectus.
Superior rectus. And that is, well, here's still a bit of the vein. Oops. That's a bit of the superior rectus. I'm not going to be able to, because these sections are so thick in the MR, you just don't see things, you see them in chunks, not as nicely sometimes as in, here's the superior ophthalmic vein on the right side. Coming up a level, nice lacrimal gland on the right side. You don't see it so clearly on the left. Nice lacrimal gland on the right side. This is either superior rectus or maybe more likely levator palpebrae superioris. Why do I say that? Levator palpebrae superioris has a very narrow origin and then spreads out like a fan. Superior rectus has a wide origin and stays there. So if I thought this had a narrow origin, I'd call it levator palpebrae superioris. Coming up a level, nothing new of excitement, nothing new. Coming up. Up, up, up.
Deploy.
Right, deploy. You're a born radiologist. Or you're the person who'll give this lecture next year. Black, that's bone. Black is bone. You know, when I used to lecture second years, and after having all these series of lectures, I'd put up an MRI of a knee, and I'd point to a big black thing, and I'd get all sorts of answers. I cannot be that hard to remember that in an MR, bone is black. All right? There's the outer table of bone here. There's the inner table of bone there. That's the diploid that we're seeing with a little fat in it, probably. Coming up, 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 and the end of the top of the skull. This is appropriate because Halloween is coming up. These are a series of MRs from front to back. So these are coronal sections. Giant frontal sinus in this person. We're right at the front of the orbits. We go backwards, backward. Here's something which seems to cradle the eye. Here it is on the right side. Right, that's the inferior oblique. Very good. And you can almost see it curving up on the lateral surface of the eye where it inserts here. Again, near the front of the orbit, that's where the inferior oblique is. It's right at the front of the orbit. Lacrimal gland is at the front of the orbit, superolateral. Here's our friend, the inferior concha. Ooh. Oh, I fooled you. Yeah, here's the cristogalli. Here's the black is the bone of the cristogalli. The white is the fat in the fatty marrow. Big maxillary sinus. Oh, this is tough. Remember, this is the inferior concha here. There's the middle concha there. It is making a bulge in the floor. All right, that's right. This is the air cell which causes the bulla ethmoidalis. The bulla ethmoidalis is a bulge in the lateral nasal wall under cover of the middle concha, and the reason it's bulging there is because a big air cell is in it, and this is the air cell that's causing the bulla ethmoidalis. Nothing exciting going on here, and now you can see everything in this MRI of the orbit. You can see the optic nerve, which is right in the middle. All of this is fat. You know, most of the back half of the orbit is fat, just with muscles and vessels passing through it. So you can see the optic nerve right here in the middle. On this side, here's the optic nerve. On the right side, you see the muscle that is medial to it, the medial rectus. You see the muscle that's lateral to it, the lateral rectus. You see the muscle that's inferior to it, inferior rectus. You see the muscle that's superior to it, superior rectus. And you see this little thin muscle. Yeah. Levator palpebrae superioris. On the right side, again, superior rectus, levator palpebrae superioris, medial rectus, inferior rectus, lateral rectus, and then this one other muscle. And that's the superior oblique. Very good. We see two vascular structures that I feel I can identify. One which sits on the inferior surface of the superior rectus, superior ophthalmic vein. One which sits more medially. After it's crossed the optic nerve, it will run along the upper edge of medial rectus, and there's the ophthalmic artery, which runs along the upper edge of medial rectus to get to where it's going. So you can see lots of stuff. Going backwards, backwards, and they're all converging. Just now. Obviously, this is temporal. I mean, obviously, it's temporal. Here's the outer table of bone here. Here's the inner table of bone here. So this is something that's lateral to the outer table of your skull, so that's temporalis. Here's all big temporalis muscle. Right here, it's a little tough to say whether this is bone or, in fact, one of the other numerous things that appear black. Hair does, bone does, and so does tendon. On this side, very clearly, is the tendon of the temporalis, and on this side, this is tendon of temporalis. It does go into the anterior edge of the mandibular ramus, so I'm not 100% sure whether that's still tendon of temporalis or the anterior edge of the ramus. Now we see our parotid gland on the outer surface of the masseter, and nothing else exciting. By this time, now I can see fat in the marrow of the mandible. So this very well is the anterior edge of the ramus of the mandible. On this side, here's the medial pterygoid coming down to insert on the angle, and here we're catching the lateral pterygoid in section as it's going front to back. As we go, this is probably the lateral pterygoid plate right here. As we go further backwards, 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 these do exactly what they should. backwards, and we see, the lateral pterygoid ending in what is the condyle of the mandible. On the left side of this person, we see the sphenoid air sinus and this thing, which lies lateral to the sphenoid air sinus and is either air flowing, blood, or bone.
Blood.
Yeah, flowing blood. In what?
Cavernous sinus?
Yes and no. It's something within the cavernous sinus, which is the internal carotid artery on this side. We see it actually coming up, and it comes up. We're at the back of the cavity. It comes up, shoots forward, and then leaves again. So that happens to be internal carotid sinus. What about this thing, which is gray? So it's
Capsule of the temporomandibular joint?
yeah. That is not the capsule. That is something we're going to talk about in depth in about 2 minutes. That is the disc of the temporomandibular joint. Very important if you are a dentist or orthodontist. And here's our longest capitis. I'll just tell you what it is. Seen in MR. Dens. That's the dens. Bone. And the answer to this is bone. In outer table, to be specifically. Why devote time to this since you're not going to be dentists? You devote time to this because it interests me because this happened to me. So, I'm minding my own business one day, eating my lunch, when all of a sudden I hear a clicking sound on the left side of my head, seemingly emanating from the vicinity of my jaw joint on the left side. Every time I open my mouth. Drives you crazy. I don't know if any of you ever had this. Drives you absolutely crazy. You cannot open your mouth without this clicking. It goes on like this for days and days, and then it stops. And I figure, okay, sometimes things come and sometimes things go. I'm happy again. Week goes by, sitting there minding my business, eating my lunch, and the damn clicking sound comes back again. Every time I open my mouth, click, click, click. Said to myself, this is going to get better, because it did last time, it will this time. Well, the clicking went away because I opened my mouth once, it clicks, and then this excruciating pain happens in my jaw. So terrible that I cannot open my mouth anymore because it's even very difficult to give a lecture if you can't open your mouth. Every time I go to open my mouth, an excruciating pain on my left jaw joint, my left temporomandibular joint, so that I can only open it, I have to mince my food into tiny little pieces and start to in between my teeth. It's really terrible. Eventually, it got less and less as time went on. And I went for some treatment, which was nothing really, it didn't help it at all. But it eventually, after about 2 months, took about 2 months, as it's gradually diminished, went away completely. And I now don't have a click, and I don't have excruciating pain, which is the best of all situations to be in. So, because it happened to me, I thought it would be interesting to tell you about what happened to me. This is a drawing of the temporomandibular joint. Here's condyle of the mandible. Here is the interarticular disc. I don't even know how many of you saw it in the section. And when we see it, we just look at it and throw it away. Yeah. But it's really a very interesting, complex structure. And if you look at it in section, it does have a bulging part posteriorly and a bulging part somewhat smaller anteriorly, and they're connected. If you look down on it, if this is a real thing, that bulging part anterior really is the anterior rim called the anterior band of the TMJ disc. And the one posteriorly is called its posterior band. And in between them is a thinner zone, a thinner region called the intermediate zone. And the anterior band is connected by some tissue to the articular eminence of the temporal bone, which forms the cavity for the jaw joint. The cavity is called the glenoid or mandibular fossa. That's in the temporal bone. And the posterior band is connected to the temporal bone and actually also to the back of the condyle by this thing called the bilaminar zone or retrodiscal tissue. You will not need to know these terms, I'm sure, in this course. I don't even think they need to know any of these terms in this course. But that is important if you're going to understand what happened to me. All right. So, this is available online for free in YouTube, I believe. This little movie, not of me.
This is a normal temporomandibular joint. The disc is...
That's Swedish for normal joint.
quite concave.
All right, so you can see here's the posterior band right there, seen in section. Here's the anterior band seen in section. Here's the intermediate zone. And the retrodiscal tissue you'll see passes from the posterior band to the temporal bone and to the back of the condyle.
And it's located in a superior position. The central thin part of the disc is consistently lying in between the condyle and tubercle.
A couple of things I want to say now. When your jaw is closed, here's the posterior band there. When your jaw is closed, that posterior band is supposed to be anywhere between the 10 o'clock and 12 o'clock position to be normal. If the posterior band is not in this zone between 10 o'clock and 12 o'clock, it's displaced. But this person has a normal 12 o'clock position for it. And pay attention, he's going to mention that the motion of the condyle on the undersurface of the disc is rotation, whereas the motion of the disc on the articular eminence is translation. So you get these two combined motions every time you open your mouth.
During opening, there is rotation in the lower compartment and more of translation in the upper compartment.
You can feel your condyle go downwards and forwards, and then backwards and upwards when you close. That is not an axis of rotation. The condyle is not the axis of rotation. The mandible is elsewhere. That's why the condyle moves downwards and forwards when you open, and backwards and upwards when you close. So, this is the MRI of me when I was during my period of intense and excruciating pain every time I opened my mouth. The right side are the upper two images with my mouth closed and my mouth open, and the left is the side of the pain with my mouth closed and my mouth open. So on the upper left picture, that is the right side mouth closed, do you think you can spot the posterior and anterior bands of the disc? Here's the condyle right there.
Okay.
That's the condyle. Here's the articular eminence right there.
Okay, yeah. So then this is posterior and this is anterior?
Yeah, so you're absolutely right. This little gray thing here, little gray thing is the posterior band. This little gray thing here is the anterior band. This is normal. Even though it's at 10 o'clock, compared to what we saw before, this is considered normal. Anywhere between 10 and 12. 12 would be if it sat up here, mine sat there.
So on the damaged side, it's been shifted forward to like 9 o'clock.
Yeah, where is it on the damaged side?
There.
Yeah.
Posterior.
The damaged side, exactly. The damaged side is right there. Here's the posterior band, here's the anterior band. That band is 8:30 maybe, something like that. That's unacceptable. Look what happens when I open my mouth. This is fine. When I open my mouth on the right side, here's the posterior band, here's the anterior band, here's the intermediate zone, which is always between the condyle, the head of the condyle, and the articular eminence normally. Here is my posterior band, intermediate zone, anterior band. There is nothing of the disc at all between the head of my mandible and the articular eminence. The disc is completely dislocated anterior. My retrolaminar zone, it was badly torn. Every time I opened it, it would get stretched and stretched and stretched. And that each time it caused pain until it completely tore. And when it completely ruptured, and when my disc settled into a place out of the joint entirely, then I started to feel better. All right? So it shows you, interestingly, that you don't really need this disc in there, and I don't know why that is. You should, you shouldn't need it. But I felt a lot better after it completely dislocated out of the joint anteriorly, and for that I'm eternally grateful.